what to do with these patients that have near complete response. You know, there's a little bit of a concern, but are they really justified to have a total mesorectal excision or organ resection? So this is really, hopefully by the end of this talk, that's what you're gonna walk out of here. Maybe there's another option. These are my disclosures. In the outline, gonna still quickly review the current paradigm change. And in that regard, again, like what's the endoluminal approaches, and even also its future directions, robotics, endorobotics even, and then what that means. But before I go there, I like to look at a little bit to the rear view mirror and really how did we get here? And maybe the better way to understand is, you know, what have we accomplished in anal cancer? But when we talk about anal cancer, anal squamous cell cancer especially, and of course, when we mention anal squamous cell cancer, it's not possible without mentioning Dr. Norman Nigro, whom we all know, but he's a colorectal surgeon, and he was the president of the Society of Colorectal Surgery between 1965 and 66. And why we treat anal cancer, squamous cell cancer different is because of this paper that was published in 1974. He was out of options. In 3 patients, he couldn't do any surgery because it was locally advanced, and he did a cocktail, a mixture of 5-FU, mitomycin C, and 3,000 rats, full pelvic radiation. And then with that, he really accomplished a complete response. And something that was purely surgical became purely almost non-surgical. Of course, that's like almost complete response is up to 98%, which is really a success. The question and where we are now is really, can we accomplish that with rectal adenocarcinoma? And as you heard yesterday and today, we for the most part really accomplished that. And the brainchild of this is certainly Dr. Angelita Habargama, who is like Dr. Norman Nigro, changed this, and she's the one who 20 years ago, 2 decades ago, really brought up this idea and did heavy work on that. She's the first Latin American licensed colorectal surgeon or surgeon, and she's almost close to 100 years old now and still actually practices to a degree, I know. And she really was criticized for her attempts and work for what she has done. But then, you know, our society put her picture on our official national journal on it, her portrait. So what really changed? This was what you all know, pre-op chemoradiation and XRT, combined with surgery, followed by surgery and then adjuvant chemotherapy. That was our treatment. But this paradigm has shifted. How? And we heard that yesterday. Instead of doing the surgery right after the chemoradiation, we do the surgery really at the end, and chemoradiation followed by chemotherapy, which we heard yesterday is called the consolidation chemotherapy, and then surgery. Certainly, this is called total neoadjuvant therapy, and then we can change the order between chemotherapy. Then it would be induction chemotherapy first, followed by chemoradiation after. But we know from the OPERA trial that's the more commonly used approach is really giving the long course chemoradiation followed by consolidation chemotherapy, and then if residual tumor, TME, total mesorectal excision and proctectomy. And we know from the OPERA trial also complete response rates are higher when we follow this order instead of doing the chemotherapy as an induction or starting out the treatment with that. We know many advantages with that. Chemoradiation is better tolerated, and that distant disease is also cured better in a way. And patients, this is a decreased risk of positive surgical margin as well. In downsizing, downstaging, we can do better surgeries with better circumferential resection margins. And this is still being studied, the sphincter sparing approach, but I do believe with downsizing, even if we need to do TME, we may be more prone to do sphincter preservation. So in a way, also an organ preservation actually, and better long-term outcomes, because we know after TME, we have low anterior resection syndrome, a lot of surgical complication from functional standpoint as well, and these needs to be studied as well. And the goal is complete clinical response as well as complete pathological response. And then we can talk about watch and wait when we have patients with endoscopic view looking like this, and organ preservation. But then it's really super important to have good active surveillance. So we cannot just give this TNT and monitor and forget about these patients. We need to have strong, solid surveillance protocols. And what tools we have? We have certainly DRE, digital rectal exam, endoscopy, flexible endoscopy, imaging, and biopsies. Let's look at these, how important these are. But before we do that, when is really the sweet spot or risky spot, which is within first 2 years? We know that the majority of the regrowths are within first year, some in the second, but majority really within the first 2 years. So it's really important to monitor these patients with first 2 years. Because of that, most protocols really we do every 3 months flexible sigmoidoscopy, and then after we go to 6 months. We talked about that yesterday. It's a lot of scoping. Patients come back to the offices, but we don't stop monitoring these patients after 5 years. We even go up to 10 years. So and now we are starting to see our patients, more than 5-6 years period after completion TNT, and this is a large number of patients we end up seeing. MRI every 6 months for 4 years. That's a lot of healthcare burden as well for our systems, no doubt about that. CT abdomen pelvis also every 6 months, first 2 years, and then from year 3 to 10 yearly basis. What about these tools that we use to monitor these patients? DRE, which we found that initially we thought that digital rectal exam is very important, and it's still an important tool, but we know that almost 80% of the time, DRE underestimates the pathological response. So DRE is not as good. So endoscopy certainly much better. We will talk about a study, our study as well. And these are the things, telangiectasies, widening of the mucosa, losing the flexibility of the mucosal surface because of the radiation chemotherapy. These are what we are looking for complete response. And yesterday we talked about that. It's subjective. Yes, it is subjective, but there are 4 incomplete, partial, near complete, and no response. So these are 4 criteria or 4 grading system that we need to use. If something like this we see, superficial ulcer or irregularity or palpable nodule in the rectal wall, this is certainly incomplete response. This is an example of a patient with T3 and 1. And you can see here at the MRI images, the prostate is budding. Certainly this is T3, almost hitting T4 potentially, but this was read as T3. And then after TNT, this is what we get. You see there's certainly a regression of the tumor, and then that budding portion is completely regressed. And same thing on the flexible. So, but putting these together is really important. MRI is also has this grading scale, which is MR-TRG, MR tumor regression grading system that really it's also more objective criteria, and our radiologists are really very experienced in that. So 1 and 2, we consider these safe and we monitor these patients. But no matter how frequently or what intervals you monitor these patients, you need to have a certain care path, and this is our clinic care path. We always follow these rules, how frequently we do, and we need to be compliant with this algorithm and care path, and really be consistent with that. And from provider to provider, you need to have a standard approach, and all these images, MRI, flexible endoscopies need to be recorded in the electronic medical record system. This is our experience. This was published last year in DCR, disease colon and rectum. Initially, when we first started, this is first published. This is our initial study with 119 patients, and we tried to identify the predictors of complete response. Interestingly enough, low tumors, as well as lack of EMVI. So EMVI, at the initial diagnosis of the tumor, EMVI is known to be a bad player, bad prognostic factor. Low tumors, not sure, but it's actually favorable. Maybe we talked about this with our radiation oncologist, maybe focusing in more concentrated radiation might have that effect, but this somehow we found that to be effective as well and predictive. Our complete response rate in our initial experience was 37%. It's really good numbers. These are high numbers. In other words, like 60% of our patients only require surgery in this initial series. And sensitivity-wise, this is interesting for gastroenterologists and for all of us surgeon endoscopists. You see the sensitivity, like how sensitive these modalities were assessed in our study. And sigmoidoscopy was way higher than MRI, but in terms of specificity, when we combined MRI and sigmoidoscopy, we had the highest specificity. So really, again, one more takeaway message from this study is using MRI and scope is extremely important. And this was presented at a plenary session at DDW in 2023, and our overall response rate again was 37%. Subsequently, with our larger number, we again almost repeated this similar study, and our predictors were again low tumors, lack of EMDI, like we discussed before, and additionally we also identified locally advanced tumors being a little bit less associated with complete response. So if the mesorectal fascia was involved, yes, they responded, but the complete response was less commonly observed. However, we still did see a even higher than our initial experience. Our 37% complete response rate went up to, in this larger series from our institution, to 42.3. So really, almost 50% of the patients can have complete response. But the main question now is like, and I think that's what the main topic of this talk was also, but what to do when there's a minimal residual disease like this or a regrowth. And this looks like a polyp or adenoma, right? But this same patient is this. This is the same patient when she was initially diagnosed. This was a T3N1 tumor. And after TNT, this is what we found. It's very low tumor. It would require otherwise a APR most likely. You see it, it's like right at the top of the sphincter muscle. But can we really justify to do a low APR on a patient with this type of adenoma type lesion? The biopsies, which I don't think also is necessary, was high-grade dysplasia. We end up doing ESD. Like, is there a role really doing a local excision for these? Not necessarily full thickness, but endoscopic submucosal dissection. And that's what we did. This is the specimen. We removed that polypoid irregular mucosal surface. And it's important to do a good dissection, good technical excision, and pinning these down on a cork board or any specimen board. And the pathology was fortunately tubular villus adenoma with focal high-grade dysplasia. There was no break in the muscularis mucosa or any signs of invasive adenocarcinoma. And this is her follow-up after 6 months. You can appreciate the nice epithelialization of that site. So really this adds to complete responders. There's another patient that is saved and it can be used into the organ preservation bundle. And this patient is saved from having a proctectomy. This is another patient, a partner of one of my partners did send her to me after having a TNT completion, and it was a posteriorly located lesion, very hard to see, even with flexible endoscopy. Here we injected it in a retroflex fashion, and this is kind of in a retroflex fashion, started out the dissection, and you can appreciate that doing the ESD submucosal dissection. Sometimes you can go into this intermuscular plane as well between circular and longitudinal muscles, and here you see the excision site, circumferentially mucosal incision was made, and then clear margins, and the lesion is pinned on a cork board. Again, in this patient, this is tubular adenoma with high-grade dysplasia with free, deep, and radial margins. So, and this is the same patient, again, flexible scope, after 6 months or so, nicely epithelialized, and this patient also can be preserved and not have have an organ preservation. This is our original study or presentation, video presentation on ESD after TNT back in 2021, and since then we have been doing more and more cases, and I do believe we can contribute to organ preservation in patients with rectal cancer after TNT. So that 42% we have, or across the also literature, that the rates around 40 can be brought up even higher up with these type of efforts. How about new technologies? This is a robotic SP technology or endorobotic because transanally you can do this. And by the way, the SP, robotic SP is now approved just last month for transanal colorectal procedures. So endoluminal procedures, robotic TAMIS or robotic transanal approach is approved now. It's a FDA approved procedure, and we can safely do these operations in the eyes of the FDA as well. Of course, some of us were using this as off-label. So same principles can be applied also using the robot. This is transanal docking of the robot, you can appreciate. And the nice thing about SP is it goes in from a single axis, and then the arms open up and has an elbow and articulation, and of course three-dimensional view is also enabled. So this is a case again after TNT, an ESD case. This is finger in the vagina. It was a right lateral anterolateral lesion, and this is one thing that we as surgeons and advanced gastroenterologists know very well: submucosal injection. And with the robot, we can do that as well using the GI flexible injection needle, using an endoclot or concentrated viscous solution. And you can appreciate here the dissection right in the submucosal plane. The muscle is left behind. If there's a severe scar, you can take part of that intermuscular lesion, intermuscular dissection, but you don't need to go full thickness, as this is not necessary. If there's cancer, probably we will proceed with TME. Here, after washing it out with a flexible suction tubing, you can appreciate this lesion is completely removed and pinned on a cork board. Again, this patient also was saved. So with endorobotic ESD, also endorobotic submucosal dissection. This is our paper published in Annals of Surgery. They have large experience, but certainly ERSD or endorobotic submucosal dissection can be used in these patients as well. ESD after TNT in rectal cancer patients can allow us to protect the planes. So rather than doing a full thickness excision as seen here, just staying in the submucosal plane, epithelialization is much superior after the procedure. And if it comes back as cancer, you're not violating the planes, because if the excision, local excision reveals cancer, most likely you would be needing a total mesorectal excision, possibly with an anastomosis. However, performing a full thickness excision will make that defect much deeper, maybe suturing it, and your anastomosis might be compromised. So ESD in this group of patients certainly provides an advantage. Since then, we have done over 20 cases. We document pre-diagnosis, diagnosis of the cancer, regrowth or residual disease, ESD pictures, as well as epithelialization, the follow-ups. So it's important to document all these and keep it in our records. This is a group of our more than 20 patients we have done. And granted, there were 3 patients that we found cancer, and they can subsequently underwent TME or proctectomy. There was one patient that refused surgery. Still to date, he remains to be disease-free. One patient, we did find ESD. We did ESD, did perform ESD. Pathology was cancer, and subsequent TME there was no residual disease. So
Maybe we can even treat them completely with ESD, but until we collect more data, obviously, we cannot just sit on it. So we just need to still, if we find cancer in the ESD specimen, we need to proceed with TME, or total mesorectal excision. So in our series, this was about 75% complete response rate. So in conclusion, TNT obviously and watch and wait is standard of care at the moment. We all heard about that yesterday and today. But in addition to that, I'd like to mention and state that ESD and endorobotic submucosal dissection has the potential to expand the opportunity for organ preservation after TNT. And certainly we will need larger prospective trials with longer follow-up to make that a standard of care as well. Thank you very much.